My name is Anita Asgar. I'm live from the Montreal Heart Institute. So today, right heart catheterization, and we're going to do a CardioMems implantation. So this is a 63-year-old patient with a dilated cardiomyopathy. He's got a previous history of a bicuspid aortic valve with severe aortic insufficiency, and he was operated in 2014 with a surgical aortic valve repair. He also had severe left ventricular dysfunction, had a left ventricular ejection fraction of 25% in 2014. He also had a CRTD implanted in 2019. Unfortunately, over the past several months, he's had progressive dyspnea on exertion for decompensated heart failure with elevated NT-proBNPs in the range of 10 to 12,000. So it's a little small, but he is on guideline-directed medical therapy. And so his ECG shows he's in a paced rhythm. His most recent echo, though, showed a drop in ejection fraction. So he had an ejection fraction of 20%. The ventricles dilated, pulmonary pressures are 57, mean aortic gradient is 30. So we did have this aortic valve repair. He's got a bit of a moderate stenosis with aortic insufficiency, mitral regurgitation at 1 out of 4, and tricuspid regurgitation at 2 out of 4. So basically what we're doing today, this gentleman was approached to participate in a CardioMems implantation to try to maximally manage his medical therapy, to have what we call tailored therapy for heart failure based on hemodynamics. And so to start this, we're going to do a hemodynamic assessment of his heart failure, so a cardiac catheterization, and then we're going to do a CardioMems implantation, so we'll show you that. So just to refresh you on the pulmonary artery anatomy, as you can see, right, left pulmonary arteries, multiple branches. And so it's really important for us to understand the position of the pulmonary arteries, anterior, posterior, and that's really related to the CardioMems implantation. So for those of you who've never seen one, this is a small implantable monitor we're going to show you. We're going to implant in a distal pulmonary artery, ideally posterior, because the patients are able to transmit the data using a system. It's remote. They lie down on a pillow, and ideally, because it's on a pillow, you want the monitor to be a little bit more posterior so you can transmit the data directly to the healthcare team. So why do we put the sensor, the CardioMems device, in the pulmonary artery? Really what we're looking for with this type of monitoring is LV filling pressures. That's the focus we're looking for. Pulmonary artery pressures, particularly the diastolic and the mean, will correlate with that. And we're able to have passive fixation of this device in the pulmonary artery and transmit this hemodynamic data. So this is what the sensor looks like. It's got little wings on it and a central sensor, and you're going to see we're going to place this in the pulmonary artery once we've finished the right heart cath, and we will calibrate the sensor with the data that we obtain from the right heart catheterization. So you can see the sensor features. It's a very simple, it's a small device, it's very stable, no internal power supply required, and it communicates wirelessly with a small device in this pillow and transmit the data automatic. So we have a pigtail already in the aorta, and we're going to start with a multi-purpose catheter, and we're going to go up and get our pressures. So you can see his CRTD system. You can see my pigtail in the aorta. I'm coming up with my multi-purpose catheter. It's really important to take your time to do this. We use minimum 6 French catheters so we can have good pressures. So I always take the pressures as we go up. We want to make sure we see everything. Ideally, a good right heart cath should be done in end expiration. So our patient is awake and we're going to have him breathe for us. So what we're going to do now is we're going to go into the right ventricle so we can see the pacer leads, interfere with those. See if we can get in. Okay, got a little bit of arrhythmia. We're going to see if it stabilizes out. So we're going to go up into the pulmonary artery. I'm just going to flush my aorta. Try to cause a little less arrhythmia this time if we can. Oh, we've come out. We're going to try to go back in. As you can see, one of the challenges of doing right heart caths in these dilated ventricles, it's not always easy to get where you need to go. So we are in the right ventricle. I'm going to try to get up in the pulmonary artery here. I'll take the wire, please. So we're in the RVOT. There we go. So we're up in the pulmonary artery. You can see the dilation in the right side because I've got a nice loop forming in the right atrium. And I'm around my pacemaker. Yeah. So as you can see, I'm around that atrial lead. So we're going to go up and we're going to try to get this loop out. Now, I don't know if you can appreciate that, but we are around that pacemaker, which is not optimal for trying to deploy a CardioMems. I think in this particular situation, I can take a pressure here, but this is not an optimal position to be in to implant a CardioMems, so we're going to have to pull it back and recross so that we don't have anything going over these pacing wires. We're going to do the saturations because that's how we're going to calculate our cardiac output. So what's our PA pressure there, Theo?
The mean PA pressure is 46 high. The systolic pulmonary pressure is 72, and the diastolic is 30.
So I would try to wedge, but I think the way this catheter is going around the pacing lead, I'm best to recross. We have our pressures. I'm going to pull this out. Oh, we're going to do this over the wire to not put any undue traction on this pacemaker lead. Our atrial lead seems to have moved out of position. We're going to try to go back. A lot of gear in here. Okay, we're going to try this again. I'm going to try to make a loop with our catheter, see if it's going to go this way. Obviously, we need to get the CardioMems sheath up into the pulmonary artery. Okay, so we're back up now. Now the key is to try to find a suitable position to put our CardioMem. So as we mentioned, we'd like to be posterior. We want to be a little bit more posterior because we want to be able to calculate our transpulmonary gradient. Because at 63, it was a very good point to ask about the aortic valve. I'm not in a wedge yet, so I'm going to take my wire and try to get in a wedge. So really what we're looking at, this is a workup to try to better manage this patient, and then once we have him more stable, really understand what are the therapeutic options for him. This is where patience comes in. Certainly looks a bit more promising. We're going to flush our catheter. On peut mettre l'échelle de 50, s'il te plaît. This is a half wedge. This is not a wedge. So this is where a balloon tip catheter would be nice. We're going to come back a little more. The other thing we can do is get the patient to help us with some breathing. I think I'm going to need the wire, please. Okay, we're going to take the wire. Montre-moi un peu plus haut, s'il te plaît, Dan. I don't really like the way the catheter is pointing. We're going to try a slightly different position. Yeah. So at this point, I have a good position also for the CardioMem. So what I prefer to do is to put an exchange wire down here and then take a balloon tip catheter because I can titrate so I won't over wedge so much. Because here I'm really between an over wedge or not wedged at all. So the best option, and a stiff wire is what I would recommend. So this is an extra stiff long, only because a regular exchange wire with this many curves, it's not going to go well. It's not going to be able to give you the support. So I think a stiffer wire is better. So we're going to take this out. Keep my wire position and just take that out for me. So we have a 6 French criticome catheter, which is an over-the-wire catheter. And we're going to advance this into position. Did we test the balloon before we went in? Okay, balloon has been tested, so we're going to go in. Okay, something is blocking. So let go. You're twisted around. Okay, so just let me advance. Okay, I'm coming up. You can follow me. Centre, s'il te plaît. Okay, there we go. Okay, so my balloon tip catheter is down. All right, so we're going to aspirate, and now we're going to try to get a wedge here. I'm going to pull it back. Balloon is down. Got to make sure I have... So we're already in a wedge position, but we're going to bring it back. I have good flow back. Excellent. So now we're aspirating well. We're going to flush. We're going to connect and get a pressure. Okay, so we have a PA pressure. We're going to inflate the balloon, and then we're going to advance. So the balloon is up. We're going to try to get a wedge. And here we go. So you can see how fast that is when you actually, have the right equipment. So this is our wedge. We've got respiratory variation. Prenez un grand respire, s'il vous plaît. So you can see here, you've got an elevated wedge. You've got a mean wedge of 30. You've got a V wave of 45. So all V waves don't mean mitral regurgitation. So it's one thing we always have to remember. A high V wave in the left atrium can mean mitral regurgitation, but in a setting of heart failure where we know this patient has 1+ to 2+ MR, this is probably more an indication of increased filling pressures, LV noncompliance, a dysfunctional left ventricle, and that's essentially what we see. This is a beautiful wedge. Here we can calculate his transpulmonary gradient. We're still waiting on our cardiac output, but we know the transpulmonary gradient is going to be about 14. So that's going to give us, so he's got a cardiac output of 2.8. We've got an index of 1.3. We've done this. Now I think we're going to go ahead and try to find a suitable position for our CardioMem. So let's see where we are. So now we're going to take some dye and try to figure out if we're in a good spot or not. Put the balloon down. So again, we need to have certain sizes associated, but we want at least a PA dimension of 7. It's smallish. We're going to have to go a little bit more proximal. And where the sensor goes, we want at least 10. Okay, so let's have a look. Comb is not optimally positioned. What I'm going to do is it wants to come back, so I'm actually going to inflate the balloon to stop it from moving. Just going to aspirate, make sure I'm not in a wedge. Okay, that's better. Okay, we're going to try to get a picture here and just see where we are. So it looks like there's a bigger branch that's more vertical. X-ray technologist who's doing all the measurements behind the scenes for us. Maybe measure a bit distal, exactly. So she's got 4 distally. A little small for what we want. I did see a bigger branch, more vertical. What we're going to do is try to get in there if we can. We're going to come back. This, like I said, is a bit harder to steer. Ich fand den geht's like. I'm going to take a wire and see if I can get myself in that vertical branch. We haven't opened the device yet. I just want to make sure I have a good landing zone before I open it. This is not where we want to be, so we're going to come up a bit. Aha! So this is where we want to go. We're going to see, this looks much better for the CardioMems. We like something that's vertical. Everything sort of tends to follow much nicer when it's vertical. I'm going to just hold that. Yeah, so that looks a lot more promising. So Vicky, if you want to measure that for me. We also have the LV lead as a landmark. Theoretically, we're going to need to be below that LV lead. So I like that position. So this device is implanted over a 018 wire. So as you can imagine, very floppy, not a lot of support. We're going to want to get that a little more distal into one of those other smaller branches so that we have enough support to bring the system over. Lots of curves to get up through. So we don't have the luxury of a stiff wire, but we're going to do the best we can with this one. Floppy tip, 018. So this is what we're going to use. So the CardioMems is an over-the-wire system. Okay, so my wire is distal. I'm going to make sure my balloon is down. And then we're going to take out very gently this system without losing our position. I'm going to start pulling this back. I don't mind if my wire curls up. I'm going to have Theo remove this for me. We're going to keep our eyes on that wire. Background information, before you came on, we put in a 7 French sheath in the groin to pre-close with a per-close. We do need a 12 French venous access to put the CardioMems in. So I do have a 12 French catheter, a 12 French sheath, I should say, in the right femoral vein. All right, make sure our wire is long. Okay, so we're going to take the CardioMems system. I'm going to show it to you on the table with a bowl. So hopefully you can see this. The system comes like this. We need to flush it. It looks like a simple balloon. It's not, but we're going to flush it. Flush the inside. And then we have to activate this in saline. So I'm going to take it out so you can see what it looks like. F8. This is what it looks like. Small. The wings are kind of wrapped around the catheter. And when we're ready to deploy it, the wings will pop out. We do have to activate it in water. So we're going to put it in water. We need to count to 15. Counting to 15. Okay, here we go. So once it's activated, we're going to put it on the wire. It's over the wire system. I will put it on and we're going to advance. So the 12 French is obviously for the body of the sensor. You do need a 12 French to get this in without damaging it. Have a look at our wire here. There we go. Beautiful. Thank you. We're going to advance over the wire. Okay, so the wire should be coming out soon. Okay, so we're going to keep an eye on our wire. And I'm going to pinch this and put this in. You have the wire control?
Yes.
Okay. In I go. Okay, so the sensor is in. Watch the slack on the wire. Put a little tension on my wire for me. That's perfect. I'm coming up. You're good? Here we come. If you remember, our landmark is this LV lead. We need to be below it, and we're below. There we go. So I'm happy with that position. If you want to see a cine of that. Sorry, I'm talking to my Abbott rep here. Okay, so we're going to deploy this here. So how we deploy this, very simple. There's a blue dial or a blue screw cap. I just unscrew it and then pull it out and gently watch. The wire is still in place. I'm going to pull. I'm going to gently remove. There we go. So I don't know if you could, I'm slowly pulling out the rest of the cable. So we're not done yet because we're still going to have to measure pressures and calibrate this. I'm just gently pulling out and we're out. Now what we're going to do is going to pull out the catheter. And again, you have to be gentle because we don't want to grab one of the wings and pull the device back. So we're just going to very gently bring this back. You can see I don't know if you could appreciate that, but the catheter came back. My device is stable. I'm just going to pull this catheter out. Okay, do you want to pull that back over the wire? Very gently, watch your wire position. Perfect. Okay. So the deployment catheter, or the delivery catheter, I should say, is out. Now what we have to do is actually go back into the pulmonary artery and measure the pressures, and we're going to calibrate this. So again, we don't want to dislodge anything. Probably the best thing to do is take the criticome. So we'll take the balloon tip catheter again. We'll go back over the wire, but we don't want to go too close to the device. You're going to see as I come up, I'm going to move to a slightly different position. And then we're going to calibrate, and we're going to put this pancake-like device underneath the patient, and the machine's going to read, and we're going to see how we are with our signal. Okay, so we're going to see our wire position. We're good. I'm coming up. It holds a little bit of tension for me, and I'm coming back up. You just have to be careful. The last step of this is to pull out the 018 wire. What you don't want to do is hook the device. I just need to make sure that it's straight. So I'm just going to leave that up there. Okay, I just want to come out. Okay, so now I'm out. There we go. Okay, so now we can actually measure the pressures and we're going to calibrate. One of the really interesting things, if you look at this PA pressure trace in green, you see that second notch on the PA pressure trace, and that's that V wave that we saw in the wedge around 45, 44. I mean, it's got a little bit of arrhythmias, but you can see that well. On peut juste monter le tube. Elle va mettre l'affaire. So she's going to put the calibrating disc underneath the patient. And we will calibrate by me measuring a PA pressure, she's going to enter that in the computer. Tu peux le mettre en AP, en fait. So she's a good signal. So she's got a good signal on her machine. So she's going to enter the data. And this is what we're doing. We're doing the calibration. So when the patient is home with his pillow, we've already been calibrated, and we'll know the data is accurate. I'm just going to take a cine image so you can see what that looks like. So that's the pancake. You can see the little oblong feature with the 2 dots on either side. That's our CardioMems. 62, 24, 41. So I'm just reading out the pressures to her so she can do the calibration. 41. They have the cardiac output. The nurses are going to be able to give that to you. It was 2.8 with an index, I think, of 1.3. 65, 23, 42. 42. So as we finish up calibrating, we will remove the catheters, and we have a radial. We'll take out the radial, and then we'll close the femoral. So 1 per close. We pre-close the device, pre-close the vein, and then we'll just take out the 12 French and close. And then the next step for this particular patient, optimization as much as possible, the medical treatment. Really, once he's optimized, decide, what's the next best course of action. So I think if there's going to be a surgical intervention that's going to have to happen here, it's really going to have to be considered something more definitive, I think, than aortic valve replacement, but perhaps considering, advanced therapies, be it mechanical assistance or transplant. Last reading, 73, 23, 41. Yep, we can remove the antenna. So we're going to take out that antenna. So the calibration is done. Okay, I'm going to take out this PA catheter. Just going to pull it out very gently. Okay, so the PA catheter is out. We're going to remove our pigtail. I'd like to see my slide. This is the delivery system which you've seen. So you've seen what we've done, vascular access. We did a right heart cath. We started with a multi-purpose catheter. As you can see, some of the difficulties with a multi-purpose catheter, we couldn't get a great wedge. Put a stiff exchange wire in, changed for a balloon tip catheter. Got a very nice wedge. We've calculated the cardiac output. We did a pulmonary angiogram, very targeted pulmonary angiogram to find a right position for our CardioMems, and then we implanted it, which took, all of 7 minutes to do. So these are the steps of the procedure. Obviously, gain access to the PA, do an angiogram, cannulate the target vessel, deploy the sensor, remove everything, and then calibrate the sensor. 6 steps. Doesn't take terribly long, but it is important to do this in a systematic fashion, evaluate all the pressures. We're not here just to implant the device. We're also here to understand the hemodynamics. So we're just going to take out everything now. So the pigtail catheter is out. I'm going to close up the vein. So we did a pre-close with a per-close device. We're just going to close this up, and we're going to be done. You could take the wire out. I don't need that. Okay, I'm just going to take out my 12 French. That's it. I'm going to put a small suture in the skin. Probably don't even need to, but I will do it. And now we're done.